Thanks for this lovely talk. It's actually quite a simple topic, so we should catch up a bit of time as well. When is surgery better in a greater than 75-year-old? I've got no conflict of interests. So how do we decide? Well, we use evidence. We'll use experts, we'll apply that in an MDT and come up with a decision of when an operation is most suitable for an individual patient, not a group of patients, but for an individual. That's what we're always trying to do. So, and we use the guidelines. What do the guidelines say? Well, they should all have TAVI. But that's not the end of the talk, don't worry. It is a 1A indication for TAVI in an over 75, but actually there's lots and lots of indications for surgery where surgery is better, and that's what I'm going to run through now. So is it all 75-year-olds TAVI? And the answer is no. I'm going to split it into aortic stenosis first, and then aortic regurgitation. And there we go. Gosh, lots of factors that we need to consider in individuals to see which is the best approach. There's three groups or categories of when surgical AVR may be favoured, and we've split them into patient characteristics, anatomical and procedural factors, and whether they need concomitant procedures at the same time. So starting with clinical characteristics. Low surgical risk, this is a really interesting one. This is in the guideline. If they're low surgical risk, maybe you should consider surgery. So I did a quick Euroscore 2 on a 75-year-old, class 2 breathlessness, no other comorbidities. His predicted mortality is 1.63%. I'd say that's pretty low. And if it's the same if we go up to 80, if you're a fit 80-year-old, your surgical risk is low. So that's interesting, isn't it? Younger age not applicable to this talk. Endocarditis, yes, of course, you're not going to put a TAVI valve into an aortic valve full of vegetation. So we're going to operate on all over 75-year-olds with endocarditis. Anatomical and procedural factors, lots of these. So these are the technical ins and outs of TAVI. We all know that transfemoral TAVI has excellent outcomes. It's a very good approach. We know that all the other approaches are not quite as good as that. So there's plenty of other ways to go in. We've done a lot of axillary. There's carotid, there's direct aorta, there's transcaval that makes me wince, and there's LV apex, which is kind of gone because of the risk. They're all associated with vascular injuries and bleeding. They're not straightforwards. And certainly on our MDT, if they do not have good femoral access, then we'll consider surgery. Annular dimensions, they may just be too big. That's the most common thing, is the aortic annulus is just too big for the current TAVI devices we have. So occasionally we'll operate on an 80-plus-year-old where the TAVI valve doesn't fit. And if they're fit, they do very well. We've had a talk on bicuspid aortic valve and TAVI just now, excellent, so I won't go into that anymore. And then there's other little factors like, is the coronary ostrea too low and too close to the TAVI valve, and it's extreme calcification, which makes them worry about annular rupture. And in these, again, we can do surgery relatively safely. So all of these are going to go for surgery, not TAVI. Thrombus in the aorta LV, that's very rare, but of course you don't want to put your safari wire into a big thrombus and stir that up, so of course they can have surgery. And then the third group, if they need something else doing, most commonly it's grafts, and the grafts are not particularly suitable for PCI, so triple vessel disease, heavy calcification, all the standard things, they may come for surgery instead, do better. Severe primary mitral valve disease, yes, you're never going to leave that. So there's no point in my mind in doing a TAVI valve with somebody with severe MR or severe TR because they're not going to get the benefits. Ascending aorta dilation, needing intervention, yeah, so you can't do a TAVI in those. Septal hypertrophy requiring myectomy, it's in the guidelines, whereas hen's teeth, you probably see one every few years, but yeah, if they've got HOCM and they need a myectomy as well, yes, you can do surgery. And I've put one on which isn't in the guidelines, concomitant AF ablation. very good evidence that this is important. If you've got a 75-year-old in AF needing an AVR, I think they're better with AVR and a Cox-Maze 4. So one worth considering as well. Aortic regurgitation, very simple, don't do a TAVI. It's not in the guidelines, they need surgery. I do realise there's the Align-AR trial ongoing with the Jena valve. This is a feasibility study, 180 patients, it works. It may be a great option in high-risk patients, but at the moment, TAVI is not really a good option for AR. The big elephant in the room, and this is I always talk about when I come to a TAVI talk, we've just seen some great talks, and what's nobody mentioning? What's the really most important factor here that seems to get missed? And it's durability of TAVI valves. We don't know. We've got up to 5 years. I realise it's early and we don't have data beyond 5 years, but we only have 5 years. Why is that important? So a lesson from history, Toronto SPV valve, I don't know if any of you remember it in the audience. Lovely stentless valve, fantastic hemodynamics, as good as a TAVI valve. 5 year, no structural valve degeneration, absolutely fantastic valve. But after 5 years, fell to pieces, withdrawn from the market. You've got to look at 10 or 12 years on valves. 5 years is not enough. It's really not, and I'm hoping we get some more data on that in 5 years. So that valve's now in the National Museum of American History, which I thought was probably the appropriate place for it. I wonder if we'll see some TAVI valves there too. And just coming back to that age of 75, this is where I'm going to finish off. You'll all be glad to hear. So how long do you expect a 75-year-old to live in the UK? Well, it's not that long, actually. On average, it's 78 for a man or 82 for a woman. So yes, tissue valve is probably going to see them out. But as we're talking about what we're looking at now is lifetime journey, redo interventions. So what if you get to 80? Well, that's really interesting. If you reach 80, you're likely to live until you're 89 in the UK. So if you're one of those fit 75-year-olds who make it to 80, you're probably going to make it to 89 or 90. And then suddenly we're asking 15 years from that TAVI valve from the age of 75, and it's not going to last that long. No bioprosthetic valve really lasts that long. So I think we need to think carefully. Not all 75-year-olds are the same, and those fitter ones may be better served with a bioprosthetic surgical valve up front as first option, and then valve-in-valve TAVI. And better be a museum in Graham. So many 75-year-olds better served by surgical AVR than TAVI due to all those reasons I've shown you, and maybe we ought to be thinking about the fitter ones as well. TAVI is still a great option, though, in the elderly and the unfit population, but we do need to know 10 and 12-year outcomes on those TAVI valves before we send all our patients down that route. And I think I'll conclude there. Thank you very much.
Thank you very much. You can sit with us, but maybe we have a couple of minutes for questions. Okay. Any questions from the audience? I can give you the microphone if you want to say. Oh, no questions from the audience?
No, great.
Mark.
Okay.
Yeah, Mark. Thank you, Mark.
So do you have data on longevity of surgical valves in a very young population? Yeah. Oh.
That's cool.
Yes. Yeah. Absolutely. So in elderly people, you can split them into deciles, 8-year-olds, 7-year-olds, 6-year-olds. As you get younger, bioprosthetic valves degenerate much more rapidly. In a 50-year-old, they fall to pieces starting at 5 years. So absolutely, they behave very differently in different age groups, and that's why I'm a huge advocate still of mechanical valves in the under 65. Anybody under 65 gets a mechanical valve if they can and they agree to it in our practice. And I push the boat a bit further. I mean, a very, very fit 70-year-old whose parents all lived to 100 may get a mechanical valve, and they choose that because they don't want re-intervention. But I think we forget about mechanical valves. I know they've been around for a long time. They're still fantastic, and in younger patients, bioprosthetic valves wear at a much accelerated rate.
Okay, so apart from the, if you don't mind the question from me, apart from just looking into the risk of the patient of 75 years old, there are morphological characteristics of the valve, of the aortic root, coronary disease, which may be surgical. I think Mark may help with answering that question. Well, you're welcome to answer it. It's not just about the surgical risk. And also I wanted to comment that although the risk shown from literature is about 1.67 or 1.7%, the actual risk in the UK, in the Blue Book, in aortic valve replacement only for aortic stenosis without coronary disease is 0.9%. So I'm saying that because I'm proud of that. I mean, it's just the UK risk for surgery is much lower than the risk for surgery that is published in the literature.
It is, and I don't know exactly why that is. I don't suspect we're a lot better surgeons. Maybe we select patients better. I don't know, but isolated AVR is an extremely low-risk operation.
But morphological characteristics, even in patients of moderate risk for surgery, just from a perspective of risk score, will negotiate surgery rather than transcatheter aortic valve intervention in some patients. For example, not only a very small root, but heavy calcification, small sinuses of Valsalva with risk that the TAVI valve will seal the sinuses, low coronary. So I think we need to look more into the depth of things that are making us make a clinical choice, and particularly what Mark said initially. I think it's expanding in our team at surgery as well, looking at the CT is not only for the interventional cardiologist, it's also for the surgeon. So low implantation of the coronaries, again, which will risk coronary occlusion at the moment of TAVI, will also be make a case for surgery.
Yeah, and I think one area we were a bit behind on TAVI valves have fantastic effective orifice areas. They are really, really impressive hemodynamics. One thing we as surgeons probably have been guilty of, and maybe still are guilty of, is patient prosthesis mismatch and not getting a big enough stented valve in. And we certainly look now towards root enlargement much more aggressively than I think we used to 10 years ago in our unit. And that's probably going to help outcomes as well, because I'm a great believer that's a significant factor. And we should maybe thinking about root enlargement more often.
Absolutely. I think we triggered the question from the audience, so we'll take that and then finish with the session.
Yes, excellent session. It's George Chrysopoulos from Oxford. I think what we're discussing here is having a great MDT. If you have a great MDT, then you define which patient, irrespective of age, is going to go to which modality of therapy. And we at Oxford, I've been there for 11 years. For 11 years, the straightforward AVR replacement is zero mortality. But that is because we choose the patients and we divert the ones for surgery and the ones for the TAVI appropriately. And when we get to the MDT, I think we need to move into being able, from the surgical perspective, to deploy the full section of valves and techniques, not just stented valves, mechanical, biological. We have sutureless valves, we have root replacements, we have all those techniques that we should be able to deploy. And every MDT should have the capacity to offer all those options. And when we get to that, I think this is a time where we serve the patient to the best of our capacities. Thank you.
Yeah, thank you for this. So I think that's a comment to close the session with, that actually the best care of the patients is decided in the MDT. And because this is a teaching sessions for the consultant cardiac surgeons of tomorrow, we need them to learn that actually they need, the MDT is only as good as the individuals that form it. And each of them has to be informed well in order to pull the case into their direction if that's the best thing for the patient. So a well-informed interventional cardiologist and a well-informed imager and a well-informed surgeon will make a good MDT. And all these characteristics that the other team is fighting for, like morphological characteristics, need to be known by both teams in order to have a fair discussion for the patient at the end of the day. I wanted to also make a little comment about a patient which comes in heart failure with aortic stenosis. That it's not necessarily a surgical turn down always, because actually if the left ventricular systolic dysfunction is low purely because of afterload mismatch in severe aortic stenosis, that improves by magic at the end of surgery. As soon as you replace the aortic valve, the systolic function of the left ventricle improves, and the patient is not necessarily of a much higher risk, although it's impressive initially. The case that Mark presented was cardiogenic shock, so that might be a bit more at the extremis of heart failure, acute heart failure, but yeah. So thank you very much for staying till the end of this session, and enjoy the lunch break.